morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and the Vice Chair for Quality and Innovation at our Department of Family and Community Medicine at the University of Toronto. I'm delighted that we can continue to bring you these COVID community practice sessions together with the Ontario College of Family Physicians. We're now, I think, at our 48th session after 2 and a bit years and back after a bit of a summer break. And I'm going to turn it over to Liz to introduce the session.
Thanks so much, Tara, and great to be back with everyone after this bit of a break, although I'm still holding on to summer. These are our amazing panelists today. We also have Dr. Chris Simpson, who will be joining us, and they will be introducing themselves in a minute, so I won't go through that, but it'll be terrific. And just so you know, you will get an email about the details around the credits that you can get for this program. That'll come by email. Next slide. I'll read the land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I am calling in from unceded Algonquin and Anishinaabe territory. So I wanted to speak to this study which just came out in the CMAJ in early August by Janet Smiley and colleagues. And Janet may be somebody who you're familiar with. She's an amazing physician, Métis, and I think she's also now the head for Indigenous I guess, research and program and efforts at Unity Health. So this was taking a look at vaccination rate and COVID rates among urban Indigenous populations in Toronto and London specifically. So those two slides at the bottom really just point out what we're seeing, which is despite, I think, really there were very concerted efforts to try to support vaccination rates in Indigenous populations. You can see the blue with the bars are the cohort of Indigenous in Toronto on C and London on D, lower than what you see for the rest of the population. So just the need for us to pay attention to ensure we're engaging those communities in efforts to collaboratively and with their leadership reach out to and support vaccination in these populations. So ongoing efforts. Tara, I'll hand it over to you.
I'm hoping that we will have our partners from the Indigenous Primary Care Council at some point come on to support us to understand how we can actually partner better with our Indigenous populations. So as just a reminder that this session is Main Pro accredited and part of a larger series, and you can see our past sessions via this link. Last time around was early July, and we did have Jeff Pernica talk about the kids vaccine as well. And so you may be interested in his slides and talk as well. Next slide. So I'm delighted to have such a great panel group today, and I'm going to turn it over to them one at a time to introduce themselves. Next slide. Upton, do you want to go first?
Thank you. Good morning. It's a pleasure to be with you today. I'm Upton Allen, Chief of Infectious Diseases at Sick Kids. My disclosure is as shown on the slide.
Amanda.
Yeah, hi there. Great to be here. I'm Amanda Adams. I'm a community family physician in Markham, Ontario, and part of the Department of Family Medicine at Oak Valley Health. And my disclosures, I did receive some financial support from the Canadian Medical Association Foundation for the Max Vax campaign, but did not receive any personal compensation for this work.
Dan.
Hi, good morning, everybody. Daniel Warshawski. I'm an Associate Chief Medical Officer of Health with the Ministry of Health in Ontario, and I have nothing to disclose.
Chris.
Hi, it's Chris Simpson. I'm the Chief Medical Officer at Ontario Health and practicing physician in Kingston.
Liz.
Thanks. So Liz Bug, I'm a family doctor in Ottawa, and I don't have any disclosures.
I'm Tara Kieran, and I've just listed where I get some grant and salary support, and none of them pose a conflict for today. Next slide. So as usual, we encourage you to put your questions in the Q&A box. I see that we already have a couple of questions there. Terrific. If you want to share resources, thoughts, reactions, please do put those in the chat. I know our panel, our community always really appreciates hearing from each other, but put your questions in the Q&A. That makes it easier for us to keep track of. Next slide. And so just before we begin, maybe I'll just outline kind of the agenda and flow for today. We're going to start off by talking about the pediatric COVID vaccine, the COVID vaccine for those under 5. We're going to start with Upton Allen going through safety, efficacy, dosing interval, kind of the nuts and bolts of what you need to know about vaccinating young kids. And then we'll turn it to Amanda Adams, who's done a ton of work in trying to support the public to know more about the vaccines and feel comfortable about them. And she'll talk about the approach she's taking in her office and the approach you can take when it comes to counseling your patients. We'll then turn it over to Dan, and Dan's going to be going through, where we're at actually in the province when it comes to vaccinating young kids, but also what we can anticipate this coming fall when it comes to COVID more generally. And then finally, we're going to end with Dr. Chris Simpson, who's going to speak about the 5-point plan that was released by the ministry yesterday, and also some plans that Ontario Health has moving forward. And through all of that, we'll intersperse your questions and come back to speakers as needed. So we're looking forward to today, and I'm going to turn it over now to Upton.
Thank you. And once again, good morning. Let me focus on the next slide, which outlines what I'll present. The first 6 or 7 bullets really focus on the burden of illness, and then I'll end with a more focused presentation around efficacy and safety. And as the next slide shows, the essence of the decision that went into making a recommendation to vaccinate kids under 5 years of age is a recognition that the benefits clearly outweigh risks. And I'm convinced that that is the case. As next slide shows, in fact, one of the things that I think is really important for us to get across as clinicians counseling families is to ask ourselves, what outcomes are we targeting with vaccines? It's often that families will come and say, well, I know somebody who got vaccinated and they still got COVID. So it's really important to focus on vaccines preventing severe illness, hospitalization, mortality, and get beyond the fact that you may not be able to prevent milder forms of infection with the vaccines. Now, in the next slide, in fact, the next series of slides are data from the United States, compiled mainly through ACIP, CDC. And the essence of this, I'll go through this really very quickly, is you can visually see the spike in COVID cases across all age groups during the Omicron era compared with prior to the Omicron era. I won't get into details there. The next slide looks at the visits to emergency departments, and you can see that as well. All age groups, including the kids under 5. Next slide looks at hospitalizations, and you can see the same trend. But also, you can see that red curve represents a younger age group. And what we were seeing with Omicron was a tendency for the younger kids to present with a bronchiolitis type illness. And in essence, some of them be likely to be admitted to hospitals. In fact, as shown on the next slide, what we saw in the United States was pretty similar to what's been experienced in Canada. Now, if you go to the next slide, the question always comes up, well, are the kids who are being admitted because they have underlying medical conditions? And as you can see, the data show that there's a roughly equal split between whether or not the kids had an underlying medical issue or they were otherwise previously healthy. And so the bottom line is that kids who are otherwise previously healthy were being admitted in the 6 months to 4 years of age range. Now, if you move to the next slide, this slide relates to the older age group. The key points here are that for the kids who were 12 to 17, 5 to 11, the take-home message was that those who were vaccinated were less likely to be represented among the kids who were being admitted to hospital. So if you are unvaccinated, you're more likely to be among the group admitted compared with those who were vaccinated. Now, if you move to the next slide, if you look at the severity of the COVID-19 related hospitalizations, what you'll see is that the red bars represent the younger age group, 6 months to 4 years. And you can see that there's a tendency for them to be represented more among ICU admissions, as well as the need for some sort of support. So again, not unlike what we would see for kids in a similar age group with RSV-related lower respiratory tract illness. Now, if you move to the next slide, I'm going to just touch on this very, very briefly. And it was interesting that they looked at the hospitalizations per year prior to when these particular vaccines were introduced in the United States. And for hepatitis A, they were experiencing less than 1 admission per year, chickenpox 29 to 42, pneumococcus 40, COVID compared pretty well, essentially, 30 to 90 admissions per year at the threshold where decision was made to go ahead with vaccination. Now, if you move to the next slide, it basically just shows the sad reality that at least in the United States, more than 200 kids, 6 months to 4 years of age, died from COVID. Now, if you move to the next slide, I'm going to skip over this one, but the essence of this was that the numbers of kids dying prior to when vaccines were implemented for hepatitis, meningitis, varicella, rubella, rota were significantly fewer than the numbers for COVID. Now, if you move to the next slide, this one is of some importance as it relates to equity considerations. And here you're looking at if you look at the Black Hispanic population, they were significantly more likely to be represented among Miss-C cases compared with the white population. And this is relevant in counseling families as far as the potential benefits of COVID vaccines among marginalized groups. Now, if you move to the next slide, I'm going to skip over the post-COVID conditions, but we don't have a lot of data there, so skip over that. And then the indirect impacts, you'll have the slide, so I'll skip over that. Now, the next few slides I'll go over very, very briefly. The key point here is that the Moderna trial, which formed the basis of approval in Canada, was done during the Omicron era, as highlighted in red. And the next slide shows the essence of this is that the numbers that you're seeing with respect to efficacy against symptomatic disease would be lower than in the pre-Omicron era. As you can see, 50% effectiveness. Now, if you go to the next slide, what interesting was that when they looked at the estimates of Moderna vaccine efficacy against symptomatic disease during Omicron, and compare this with the effectiveness data for Pfizer in the 5 to 11, they were comparable. Now, Pfizer has been approved in the United States. Now, unlike the Moderna, they didn't have enough numbers to draw any conclusions with respect to efficacy against symptomatic illness. But the immunobridging data showed that immune response is in the kids under 5 were comparable to older individuals. And if you move to the next slide, the key here in the Moderna study is that there were no severe adverse events noted. And as the next slide shows, the major side effects were local systemic, of which there were really mild side effects. There are really not much to be concerned about. And so if you move to the next slide, there are a number of questions that relate to myocarditis. And I think the key point here is a decrease in myocarditis signal with age. So as the younger you get, the lower the signal. So that's reassuring. And if you move to the next slide, I'll skip over that one and move to the next, which I'm sure Daniel could speak to as well. The Moderna vaccine doesn't have any preservatives, antibiotics, adjuvants, etc. And then moving to the next slide. This relates to the interval between doses. And I think the essence here is that the NACI recommendations or that the intervals be 8 weeks if you're otherwise healthy but immunocompromised, that's shown on the next slide, potentially a shorter interval. And if you move to the next slide, a question that often comes up is the interval between COVID-19 illness and the vaccine dose. The recommendation is shown there. But again, if you move to the next slide, you'll see a question that pops up a lot, and that is the concurrent use of other vaccines. And here, the key point is that NACI is recommended that the vaccines are not routinely given together, but you could give them. There's no safety issue. It's just that if there's an adverse event, you want to know what is causing what. And next slide is an interesting one that I often like to share with audiences. Work summarized by Paul Offit from CHOP years ago. And essentially, it relates to the question that families often have, and that is, can my kids tolerate all these various vaccine antigens? And Paul and his colleagues had determined that theoretically the infants' immune systems have the capacity to respond to about 10,000 vaccines at the same time. Nobody would ever do that, but it illustrates the capacity of the immune system to handle many different antigens at the same time. So I've covered a lot. I'm happy to stop there and look forward to the Q&A session. Thank you.
Thanks so much, Upton. That was a great overview of many of the key points of why it is that we are recommending the COVID vaccine for those under 5. There's some great questions here, and I'm going to take them one at a time. So Jenny Clement asks, does the 6-month to 4-year-old vaccine cover the variants more than the original vaccines for other ages? Or will they also need a booster in the fall with a variant-specific vaccine? Sorry.
That's a great question. There's definitely less efficacy against the Omicron strain, Omicron variant. Whether or not it's going to be necessary to give another booster later on with a new vaccine, such as bivalent vaccine. I think that is less clear at the moment. I think the most important thing, though, is for us to seize the moment to bring COVID under control as much as we can, so that COVID doesn't get a running start into the respiratory viral season. And then if the respiratory viral season with COVID included among the respiratory viruses that are cycling in late September, October, November, if it's a quiet period, then we might not have to worry too much about boosters for the kids.
Thanks, Upton. So Jenny Clement also asks, what kind of numbers were in these trials? Are they powered to pick up risks of vaccines?
Yeah, that's a really great question. There's no question that the studies were not powered to pick up rare side effects. So that's important. So an important phase of the evaluation is the ongoing safety. I think that's really important. So if you look, for example, at the, looking at the Pfizer study, for example, in the United States, they had 80 kids in under 2 and 140 in over 2 to 4. So these numbers are really small. But for the efficacy data, they had more numbers. They had up to 1,170. I'm just looking at the screen here. So numbers are fewer for looking at the immunobridging. Numbers are greater, but even over 1,000 would not be enough to pick up rare side effects. The important point is that those side effects, by definition, I guess, are rare, and the post-marketing surveillance would be important to pick those up.
There are some more questions just about this waiting around other routine immunizations, and I wonder if we can just talk a little bit about that. Again, Upton and Dan, I know you answered a question in the chat as well. So, because I think Alan Brill asked something related to the inconvenience of having kids come in for numerous appointments, and can the 14-day rule waiting can that be lifted? And I think Dan, you responded that the 14 days is a strong recommendation, not a mandate from NACI. And I wonder if you could just expand orally on what you were saying, Dan, and then Upton can as well.
Sure, I'm happy to. I think Upton said it as well. So it's about being able to identify adverse events following immunization. It's not a safety or efficacy concern from providing the vaccines, COVID vaccine with any of the routine schedule close together. It's simply, and to the point we just made, we're still trying to identify the more rare adverse events that may arise. And if we're constantly giving them at such a short interval, it's difficult to determine what particular vaccine might have led to a specific adverse event. But NACI does have some language about if there's limited ability for additional follow-up with a patient, if they're especially high risk, then use discretion and consider providing it within that 14-day window.
Thank you. So Karen Northey asks, if children have previously had SARS-CoV-2 infection, to what extent does vaccination affect benefits and risks?
Yeah, that's a great question. Daniel can answer this as well. There's no question. These are some of the data we've generated. Some of this data in Toronto as well. If you've had COVID and you get vaccinated, your immune response is more profound. How does that translate into protection? That's less clear. But it really does appear that having the combination of a hybrid immunity, so to speak, the combination of vaccine and previous infection seems to be resulting in pretty robust immune responses. Trying to put that into some sort of a public health package is a bit more complicated, because one would not have the ability to do serologies on the population at large to see who has previous antibody to COVID to the SARS-CoV-2 and how that might influence a vaccination strategy. But I think it's certainly an area that is in need of continued research.
So there's a couple of questions here, Upton, not about the vaccine for kids under 5, but more 5 to 11. Karen Leva asks, will those 5+ be eligible for a booster as they head back to school? And then Jenny Clement asks about whether kids who've been 5+ who've had 2 doses, whether they'll get the variant vaccine in the fall. Should those kids get it, will they be eligible?
And I'm happy if Daniel weigh in on this as well. At the moment, boosters were not targeted at the 5 to 11 age group. So I think it's an important point to get across. Will that change? We'll have to wait and see. I don't know that will change. But the boosters were for the older age group, and it's an issue of weighing potential risk versus benefits. But for the 5 to 11, boosters were not being recommended. Dan, you want to add anything to that?
Yeah, I would just add that we're expecting the NACI statement on 5 to 11's boosters to come like in any day now. And so we'll see what they say. But to Upton's point, it'll probably be similar to what we've had previously, which is more of a, if anything, a may be offered, not a strong recommendation, I would expect, but we'll have to see what they say. The one thing I do want to raise is that the bivalent product that is currently awaiting Health Canada authorization is only for adults. It's not authorized for going to be authorized for pediatrics, from what we understand of what the submission has been.
So Dan, actually, I wonder on that note, if you wanted to speak to the bivalent vaccine for the fall, because there is a lot of interest from people about that very specifically.
Sure, I'm happy to. Thanks, Tara. So the bivalent vaccine that is awaiting authorization with Health Canada, both Moderna and Pfizer have submitted, and they're on the kind of rolling approval they've had previously. Moderna did submit earlier, so we expect that to be the first one that is authorized, but hopefully Pfizer not too far afterwards. They are BA1 targeted in terms of the bivalent, so they're not going to cover BA5 specifically, but obviously we know that the BA1 does provide better cross-reactivity to BA5 than the current Wuhan strain that's in the previous product. Obviously timelines are up to discretion of Health Canada, but the best we're hearing is probably sometime mid to late September for authorization and some products being available. It's likely that there'll be a somewhat limited product at first, so not able to open up to the entire population of Ontario right at once. And hopefully it'll likely be targeted to the highest risk groups for the initial rollout until more supply comes in. So highest risk, as we've seen before, individuals over 70, long-term care homes, people who are immunocompromised, for example.
Thanks. So switching gears back to the, well, actually, we'll stick with the kind of the both adults and peds here. And Meeta Vij asks, do we still have to wait 3 months after a COVID infection in the pediatric and adult population to administer a COVID vaccine or booster? Dan, did you want to answer that?
Sure, I can start. I would appreciate Upton if you want to jump in on pediatric as well. That's still the recommendation. I think that we're really trying to determine now whether, post-infection with the new subvariants of BA5 sooner would be warranted. We are seeing higher rates of reinfection from BA5 to someone who's had a previous different subvariant, so BA1 or BA2, shorter than the 3 months, as short as 2 months afterwards. But even though it's a higher rate, it's still unlikely to occur. So while possible and increased risk, 3 months is still a very good recommendation. And particularly if we're looking at risk against severe disease, the coverage is still excellent if you've had infection within the last 3 months. I think what we're really looking at now is whether, particularly immunocompromised or older adults might benefit from having it a little bit sooner, but it's early days and not quite clear.
Yeah, I agree with Daniel 100%. No, what Nasi has said for the kids 6 months to less than 5, because this is a new program for them, that you can vaccinate if you're non-immunocompromised, you can vaccinate at 8 weeks post-COVID. If you're immunocompromised, you can bring that down to 4 to 8 weeks. So that's with respect to the Moderna vaccine.
And I think what we've heard on these sessions before with Alison McGeer is you're weighing the benefit of maybe some earlier boosting with the vaccine, some earlier sort of added protection with more longer lasting, better protection if you have a longer interval between COVID and the booster dose. Exactly. So I think it's not, early on we were just learning about that, but it seems more and more, and vaccine science suggests over the years that that's what you're balancing. So if someone, it sounds like, is in like a really high risk situation, that might change your mind around the risks and benefits. So Jennifer McCabe asks, do we have any information on the efficacy of pediatric immunization for COVID on transmission within a household?
Yeah, we don't have good data. The assumption has always been that particularly pre-Omicron, that people who are vaccinated would probably have overall, potentially, if they do get COVID, the illness tends to be milder, maybe less virus load, viral burden is less, and perhaps less transmission. But for Omicron, the data related to whether or not that affects transmission within the household, those data are lacking.
And then the last question I'll take before going to Amanda is from Sherry Devereaux. She said, why did NACI not recommend the vaccine outright for this age group rather than, quote, may be offered, end quote, considering the risk of disease is higher than some other diseases for which vaccines are recommended?
Yeah, it's hard to speak to NASA's choice of language, but based on the data that are available, the data that were reviewed by the CDC, by the FDA, as well as Health Canada, it's really clear to me that there's evidence that the benefits of the vaccine would outweigh risks, and as such, we would proceed with vaccination. There is no question that there is a fly in the ointment, so to speak, that was created by the myocarditis signal. And so whenever recommendations are made, one bears that in mind, and that sometimes influences the language that regulatory bodies use. But the key point is that as the kids get younger, the myocarditis signal gets weaker.
Thanks, Upton. All right, Olivia, I wonder if we can bring up Amanda's slides, and we're going to turn it now to Amanda to talk about kind of the approach she's been taking to counsel her patients and the approach we can all take as we have these conversations, including some of the most common questions that she's getting and how she responds to them. Amanda.
Great, yeah, thanks again and good morning. I just wanted to say happy National Immunization Awareness Month to everybody, which is in August, and to say to my colleagues, thank you for all you do to support the vaccine efforts for all vaccines. We are going to be, I know, discussing this morning, I'll be focusing obviously on the COVID vaccine and counseling tips and resources. And just to frame this, I wanted to say, we know that parents and caregivers, want to make the best decision for their children around the vaccine. And so I'm taking every opportunity, as I'm sure you are, to discuss and support them in making this decision. So if we could go to the next slide. So a helpful way that you can do this is to use the PROTECT framework, which is a resource developed by the Center for Effective Practice. And for those not familiar with it, it is basically to help approach conversations thoughtfully, to build trust, to share important information, and have a positive and effective interaction. So there's these 5 steps that I'll be briefly sort of going through each one with tips for speaking to parents and caregivers on this. So if we can go to the next slide. So how do we start the conversation? Well, as we say, we try and bring it up with any patient interaction, and it might be, in the context of when you're talking to your patient about, they're going back to school or going to daycare, perhaps, what we're expecting with the fall COVID vaccine or COVID surge. So you can start with positive statements, like, in my case, I would say my children are older and they're already vaccinated, but I'm happy that many of the children in my practice that are under 5 have already had their first dose. So I would invite you to think of some positive statements that you maybe use already or you could use for this step. We can go to the next slide. So then the O is to share your knowledge. So in this step, we want to, invite people. So tell me where you're at when it comes to wanting this vaccine for your children. And would it be okay if I share what I know? So that's in the next slide, please. And then on this step, I think this is the important one where you're going to tailor your recommendation. And the way I like to approach it is to either decide, find out if they've had a previous Omicron infection or if they haven't been infected at all, and tailor to this. So how do you do this? Well, if they've previously had an infection, I would say something like, we know that Omicron infection actually provides poor immunity in kids, and we do see reinfections that are common. And in fact, a recent study showed that 30% of kids don't build any neutralizing antibodies after infection with Omicron. And so what we do know, though, is that vaccination after a COVID infection has shown to provide really longer lasting and more robust immunity. And so there's great value for children, particularly those that have had Omicron, to get vaccinated. So that's sort of how you could approach that. And if they haven't been infected, you can, say something like, Omicron has infected, many kids. And for those who haven't had it, vaccination is the best option to protect them from needing hospitalization. And in fact, a study in the US found that, 50% of hospitalized kids are otherwise healthy with no underlying medical conditions. So we also know that mild COVID in kids has been associated with long-lasting symptoms, so long COVID or multi-system inflammation. So the vaccine, we know, has some protection in this as well. There's some early studies, certainly. So we can go to the next slide. And then these are, so the next part of the framework then is to address any concerns, because obviously the patient's going to have them, and naturally parents are going to want to ask you things. These are some of the common questions that I've been hearing. And, Dr. Allen has sort of discussed quite a few of these in his previous slides. So I don't know if I have to go through each specific one, but, I think maybe just to point out, for sure, I have had people saying, should I wait for the Pfizer vaccine? Myocarditis is, I'm hearing, we should use the Pfizer vaccine to reduce that potential. So I would say, with Pfizer, we want to let them know that even after 2 doses, there's really not a lot of protection at all. It's really after the 3rd dose, which is months before you'll get protection. And so we usually, so my recommendation is to get it now if you want to protect your child, because even with Moderna, it's the 2 doses plus another 2 weeks. So it's really 10 weeks until they're going to be having the full protection from the vaccine. So maybe we can go to the next slide. So this is the last step in the framework, and that's to discuss the plan, right? So we want to make this process for somebody, you know, a parent or a caregiver getting their child vaccinated is as easy as possible as we can. So looking at the, I guess, thinking about where, when, and how we're going to help them. So in terms of when, we want to review timing, maybe if they're in for a well baby visit, you know, you can talk to them about when they're going to get, you know, when they can book their vaccine for. And as we've discussed previously, it's 2 weeks between other routine vaccines if you can, and then 8 weeks post-COVID infection. And then the where, so depending on whether you're going to be able to offer the vaccine in your own clinic, or if you're the patient will be going to a public health clinic or a pharmacy, you can kind of guide them a little bit about what to expect. You know, there's often, one-on-one in the public health clinics with private rooms, and, you know, they're kid friendly. So you can kind of paint the picture of what that might be like. And then, you know, provide information sheets if they need it. And then lastly, how you're going to, help them. So it's for the parent or caregiver and the child. So we want to prepare the parent as well for a positive vaccine experience. And then there's some great resources about, you know, what they can give, what they can do, and how they can act. So how a parent can help with the experience for their child. So it gives them something that they can do. So after all of the, you know, if you have handouts, again, there, you know, if they need places to go, we can talk about resources, because if they don't book their appointment right away, you want to keep the conversation going and invite them to say, if you have any other questions, please, you know, make another follow-up with me or let me know. So if we can go on to the next slide, I'll just in the interest of time, I know there are a number of resources that are going to be linked in, links are going to be provided for these, but there, just to highlight, there's some great one-page resources. There's the Department of Pharmacy at the University of Waterloo's, Vaccinate My Young Child Against COVID-19. That's a great one-pager, as well as the needle pain and anxiety from management from Solutions for Kids in Pain. That's another one. And the Ontario College, of course, has a great web page with full of great resources and links. And then if we can go just to the final slide. So again, if somebody would like to speak to somebody at the vaccine consult service at Sick Kids, that's a great option as well. And of course, I couldn't not mention Max the Vax. So this is a partnership that I developed with the Ontario Association of Children's Aid Societies to host our Max the Vax webpage. And this has been updated for 6 months and up. And we this is a resource page. And what I do in my office is there's on the webpage, you can print out the poster, and stick it in your exam room. And there's a QR code that launches into the content on the page, which has links for caregivers and for kids. And there's FAQs there in multiple languages. And I just wanted to also just let people know that we do have a lot of free Max stickers. So if anybody is interested in getting some stickers for their office to talk about things, then there is a link on the webpage. They can order them. Thanks.
Thanks, Amanda. You've done an incredible job with Max the Vax. That is a terrific website with such really practical resources for parents, for kids themselves, and of course for us as providers. So thank you for doing that. I also want to give a shout out. You use the PROTECT framework. So that was actually developed by our colleagues Noah Ivers and Cora Constant. I can't actually pronounce her last name, but she's an ID physician in Calgary, and I'm going to find that name for you. So Cora C. and Noah Ivers, who did a terrific job building that PROTECT framework. You're going to see lots of really positive comments in the chat, Amanda, about Max the Vax. People really love it. So that's wonderful. I wonder, Liz, if you are able to just speak a little bit to family doctors doing this in the office. We'll go to the next slide. Yeah.
Yeah, for sure. So thanks, Amanda. And I really, feel there's a bit in the chat about this, like our role as family doctors here to educate, support, help parents move towards, getting ready to vaccinate these kids is so critical. I mean, we know we're the ones that they really trust. These kids get vaccinated in our offices. So beyond that, education role, of course, there is vaccinating ourselves. Totally, all of us are familiar with some of those barriers around vaccinating in office, but I really wanted to celebrate some of what we're seeing already about some creative ways and really effective ways to vaccinate these kids in office. So you can see some doing this outside. There's some images there about, vaccinating in the parks, lots of ideas around making, if you just go to the next slide, how to make the office space, you can see on the left there, more conducive to vaccinating these little ones. If we're trying to do it in a way where, you're bringing in more like a vaccine clinic and bringing in, larger groups of young kids and just that this is a really important part of what we can do as well. I'd love to hear, so these are just some examples we've put up here, but love to hear in the chat, there's, close to 550 of you online, anybody else who's been vaccinating in office, some of these little ones and what's been working and, celebrating, the hard work that we're doing. Despite I know some of the barriers to doing that. So just didn't want to lose that opportunity to talk about that as well.
Thanks, Liz. And so some of you have asked as well, will you get the resource lists that Amanda talked about? Absolutely, we'll be emailing a resource list following the session. Next slide, we also have just compiled some of these, go to the next slide, in a nice little bulleted form. And so the slides will be there for you to download as well following the session. I'm going to, and then in terms of the shout out, sorry, I should have said it's Dr. Noah Ivers and Cora Constantinescu who developed the PROTECT framework. And then I was going to turn it over to Dan shortly, but I want to do one question before I turn it over to Dan, and that's just to Upton and or Dan, who, if they want to talk about just the kids who are 5 in that transitional age, and whether it's okay to kind of have one of the vaccine doses, before 5 and then the other one after 5, or what you might recommend for that transitional age. Upton, I don't know if you want to answer that.
Yeah, so the I'm just trying to remember the NACI recommendations, but the essence of it is that if you got Moderna and you transition to 5, you can continue with Moderna. But if you did get Pfizer, it's okay. You don't need to. It's adequate vaccination. You don't need to consider it as inadequate.
Is there anything you wanted to add there, Dan? And Olivia, we can bring Dan's slides up as well.
Oh yeah, no, I agree with what Upton said. People, if you're under 5, the only product that is authorized is the Moderna one right now. So preferably that's the one. But there's language in NACI as well as some QAs that went out from the ministry detailing if you're 4 turning 5, if you're 5 turning 6, if you accidentally got Pfizer when you're 4. So I apologize, I don't remember them off the top of my head, but we can make sure that those resources are available.
Thanks, Dan. All right, over to you. How are we doing when it comes to actually giving the vaccine out?
Great, thanks, Tara. We're doing better than the US, and I'll start with that. So as you can see here, in terms of our overall uptake, this is since the start of the program and up to date as of just a few days ago. We're still seeing pretty low demand coming in for this product. So Ontario as a whole, just under 3% of the eligible population. And so you can see the numbers there. It's just over 700,000 children in this age range who would potentially be able to get the vaccine. Only 2.9% have actually come forward to receive it to date. It's widely variable by public health unit, which is something that we've seen before with other vaccines. And this follows a similar trend where Ottawa and Kingston, who have really been some of the leaders in getting vaccine out to the pediatric population, remain near the top, with some others, having more difficulty as you go down. But even those particular health units, we're not seeing anything near the interest that we did even with the 5 to 11 product. So with the 5 to 11s, we had a really huge interest up front, reaching kind of 40 to 50% of eligible within the first month, but just not the same to date with the under 5 product. We'll go to the next slide, please. This one I just thought interesting to share is where people are actually getting the vaccine at this point. So again, it's pretty variable by public health unit. The majority is still being administered by local public health units, either in larger mass clinics or in more targeted pop-up clinics. But by different health unit, you can see there's more pharmacy involvement or primary care involvement. So the HKPR, so Halliburton, Kawartha, Pine Ridge, and Temiskaming and Windsor really leading the way in having primary care involved in providing vaccine. Windsor, you can see they're barely not even anything being provided by local public health units, but in primary care and pharmacy essentially. So huge variability across the province, just depending on what makes the most sense regionally. Next slide. So okay, so that's what I had on just the current status of the under 5 campaign, and happy to answer questions. But I want to talk a little bit about the fall scenarios that we're potentially looking at in terms of vaccine generally. So obviously there are a lot of unknowns, and I don't remember, Tara, which of the slides I'm going to go through after this if we're going to talk about the curves, but we don't know, number one, exactly when the fall season is going to start or exactly which variant we're going to see, as has been the case previously. So in terms of planning, there's 2 scenarios that are kind of being the predominant ones we're looking at. The baseline scenario, as you can see on the left hand here, calls for really a strong recommendation and starting off with boosters for the high-risk populations that we're familiar with from over the course of the COVID campaign, and really trying to get them as soon as possible to get them protection, and then moving on to general boosters for the rest of the population as a whole who are lower risk. That planning is about 5.7 million doses given the uptake that's expected and given the uptake we've seen over the last couple booster doses that have been opened up to the general population. In a surge scenario, and this is where we see a changed variant where there's going to be more interest in getting vaccine, but also more need to get it because the new variant is more virulent or presents some level of immune evasion, that increases to 8 million doses roughly over a 2-month period. In that situation, it'll be a little bit more ramping up mass clinics as we've seen before and reaching out to healthcare providers across the system to try to support. Whereas for the baseline scenario, it's within the current channels that we're using right now are able to absorb that increase in vaccination. So next slide. This I just thought for interest what we're expecting for uptake. So this is based on the uptake we've seen over the last 2 rollouts of booster doses. As you can see, for the older adult population, particularly over 70, we still get pretty good uptake to date. And we'd expect it to remain in similar range, although I constantly hope for higher, particularly in that group. But once you get under 70, we see a pretty steep drop off in people wanting to come forward to get their booster doses. And you can see, all the way down into the teens that people just aren't coming forward. So these are some of the expectations. In a surge scenario where we do have increased interest in vaccination, increased level of COVID circulating, we would expect a bump in all of those. About 20% is what we've seen over previous times when we've had a bump. And that would be the coverage rate that we're expecting. So this is kind of the general look at what we would see for vaccination in the fall, given where we're at right now. The one thing on those, this doesn't take into account potential increased interest from having a bivalent product, because we're not clear exactly when that product will be available, how much better it will be in the current product against whatever the circulating strain is in the fall, and how interested people will be by having a bivalent. I think we can all guess that it's new and shiny, so probably some more people will want to get that one, and certainly many are waiting for the bivalent knowing it's coming, but still very, very difficult to predict what uptake might be for that one. Next slide. Did you want me to pause, Tara, or I can quickly run through kind of the epi?
Yeah, why don't you quickly run through like where we're at and where you think we'll go from a COVID perspective, and then I think that'll turn nicely over to Chris, who's going to be talking about the government's plan.
Perfect, thanks, Tara. So this is just a snapshot I've taken of the Omicron waves, the data current as we have it, so that's to August 6th. This is all from the Public Health Ontario website. And this is just case counts that we're seeing. So obviously we know that the initial Omicron wave was where we saw huge transmission occur. But what we've seen is kind of what's been expected after having that level of transmission, leading to a huge amount of natural immunity on top of the vaccine-derived immunity that we've had in the community. as well as what we see in other pandemics, where we see slow attenuation over subsequent waves based on the level of immunity that's building in the population. So again, a huge bump in what we had the initial Omicron. We're all aware it was much smaller in wave 6, and the current wave 7 has been smaller still in terms of what we're seeing for overall case counts. I don't have the hospitalization rates included here as well, but we have peaked just about a week ago in terms of hospitalizations for the current wave. And again, that peak was lower than we've seen in both previous Omicron waves. So somewhat what's expected for a pandemic at this point. If we can go to the next slide. This is looking at Australia, and this is for their flu season. And so this ties into what we might expect for the fall. And sorry, I should have said for the last one, if you look at the waves, they're about 90 days apart. So if we think we're going to follow the same trend as we've had for the last 3 Omicron waves, we can expect 90 days from the previous wave, roughly a good time for when we potentially would start having another fall wave, which would be mid to late September, which is certainly earlier than we normally see the respiratory season begin. But that ties into the next slides that I have here, which is what Australia saw. And we always follow the Southern Hemisphere to try to get a sense of what we're seeing for the respiratory season. This is just flu numbers. But as you can see in 2022, which is the red line, they had a very early start to their flu season, about 2 months earlier than we see on average. So this is just by week at the bottom over the year. And so about 2 months earlier for flu. In terms of the level of severity of total cases, you can see it's roughly about the 5-year average, but that 5-year average is obviously heavily skewed by the 2017 flu season that we had, which was quite significant. If we can go to the next slide. This is looking specifically at lab confirmed cases of influenza that they had in Australia. So as well, you can see this is the previous slide was just ILI reporting to hospital. This is lab confirmation. And again, seeing that 2 months before. And for this one, for lab confirmation, we are seeing a much higher peak in total number of infections compared to just ILI presentations that there were in the other one. And next slide. And this one is for hospitalizations, which obviously is a key part of what we're looking at with what their health system is at. And then Chris is going to speak to. For hospitalizations, and again, influenza confirmed hospitalizations started 2 months earlier, certainly higher than the 5-year mean that we've seen, but in keeping with some other previous, moderate flu seasons, and certainly not as bad as we've had in the 2017 flu season. So overall, I think this is telling us that we can probably expect an earlier start to the respiratory season generally in Canada as well. Again, we're trying to extrapolate and predict, but if we follow along and about 2 months earlier, then that puts us roughly the same timing as we'd expect the next COVID wave in mid to late September. So I think that's what we're preparing for in terms of seeing the respiratory season. The one thing I didn't have a slide for, but that I would note is that RSV was quite prominent in the Southern Hemisphere of the last one. So up to 40% of the children who presented to emergency department with RSV required hospitalization. So I think preparing for what is potentially going to be a significant RSV season as well is something we should be looking to.
Thanks so much, Dan. So just a reminder to everyone that we will be going until 9:15 today. That'll give us an opportunity to continue to answer your questions. But at this time, and maybe I'll ask Olivia if we can end slides. And I'm going to just turn it over to Dr. Chris Simpson. So Chris has been there for this session, and I know he has some important messages that he wanted to deliver just based on, health system recovery and everything that's been happening and is in the news.
Well, thanks, Tara. Well, first of all, let me just start by thanking all of you for all that you're doing. We certainly recognize the foundational role primary care plays in the health system. And on a personal note, I want to thank all of you for repeatedly rising to the leadership challenge over the course of the pandemic. We've seen over and over again, and this is not perhaps out there the way that it should be, that the primary care community has repeatedly risen to the occasion, whether it be on vaccinations, staffing the clinical assessment centers, or more recently doing the heavy lifting with therapeutics like Paxlovid. You've all been fantastic partners to Ontario Health in the common service of our patients. And I can see as well through my friends and colleagues I know personally who work in primary care, all of the extra hours, the exhaustion, the burnout, and the extra burden that you've all shouldered in order to keep delivering care to patients in very trying times. So taking off my Ontario Health hat, just speaking as a colleague, I want to say simply that I'm very thankful. So the government's 5-point plan, was released yesterday. The focus for the plan was deliberately on ALC and emergency department pressures. I think because these have been the extreme pressure points for the government. We all know, of course, that emergency departments and largely as well, the ALC issue are really a barometer or a canary in the coal mine, reflecting the pressure that exists everywhere in the system. And so Ontario Health, as the agency, the healthcare agency that really tries to connect all of this and operationalize things, and based on the policy direction coming from the Ministry of Health and the Ministry of Long-Term Care, will be providing some guidance to the field shortly that will be taking some very specific advice from different sectors. And we will use this guidance to talk to the roles that all sectors will need to play, including primary care, on how to operationalize the plan and prepare for the fall. So we really will need to work with you to ensure that we capture what you believe and know is the role that primary care should play. And importantly, this has to be not just the context of pandemic recovery and fall planning, as important as that all is, and I know that's front of mind for everyone, but perhaps even more importantly, in the context of the transformational opportunities that are in front of us. We need to capitalize on the blood, sweat, and tears that the pandemic's disruption has brought. So we understand how important primary care is as it touches all aspects of the healthcare system. We know that more patients access the healthcare system through their primary care provider than in any other way. And we need to make sure that all health system providers work together if we're going to achieve an integrated patient-focused system. So I want to briefly, without slides, just walk through the plan. And along the way, I'll try to highlight some of the key areas that I think relate to primary care, recognizing that the work we'll all need to do together clearly reaches beyond this plan. So the 5 points were preserving hospital capacity, providing the right care in the right place, reducing the surgical wait lists, easing the pressure on emergency departments, and then expanding Ontario's health workforce. Because frankly, no matter what plan you can imagine to put out there to try to improve things, the rate limiting step right now comes down to the workforce issues. So these actions collectively, it's hoped, will significantly reduce the risk of a hospital bed shortage during a winter surge that, as Daniel said, may include influenza, RSV, and COVID, perhaps even overlapping in time. And so these measures, we hope, will help to avoid having to take dramatic actions like we've had in the past, like pausing scheduled surgeries. And it's hoped that these actions will serve to mitigate the system congestion that is currently impacting healthcare across all sectors. So briefly on preserving our hospital capacity, it's clear that preventing respiratory illnesses is going to be probably the best tool in keeping people as healthy as possible this fall and relieving pressure on hospitals. The goal is to improve vaccine uptake to protect against both COVID-19 and influenza, and that will translate into fewer hospitalizations and severe outcomes. And antiviral treatment, including Paxlovid, is still available for free to high-risk individuals by prescription. That is a role that primary care has been a stellar leader in. Evusheld is also available and provides pre-exposure protection from COVID-19 to selected immunocompromised individuals for up to 6 months. There's some updated guidance coming very shortly on that. They'll be launching the annual flu shot campaign this year for those 6 months of age and older, with an initial focus to be on those at greatest risk, including targeted vaccines for seniors. Free rapid antigen tests continue to be available. And my ear at the announcement yesterday caught an important piece on masking. So we may hear more on enhanced masking recommendations in the fall, depending on where numbers go. On the second pillar, providing the right care in the right place, we're seeing some action on long-term care beds, and this is perhaps one of the more attention-grabbing items. There will be a hard increase in bed capacity in long-term care through the remobilization of some of the isolation beds, provided that community demand and COVID-19 risk levels remain favorable. And very importantly, there has been introduction of legislation that, if passed, will support patients being placed in a long-term care home or a transitional care setting while they wait for their first choice. Now, the devil is in the details on this one. Lots of concern about geographic boundaries, and that will be embedded into some of the regulations. And of course, this will have to be done in a way that is very supportive. But I think it's very important to recognize that patients who do not require acute care in hospital have poor outcomes when they are in a hospital bed. And so I really like to position this not just as a flow issue, as important as that is, but also as a quality of care issue. And so in the spirit of devil is in the details, we really need to make sure that we deliver on that promise of quality. There will be expanded access to supports and services that help people live in long-term care better, such as behavioral supports for patients with dementia, specialized staff resources, more on-site treatments, and upgraded equipment. There will be more help for seniors and recovering patients to stay in their homes and avoid hospital admission by expanding adult day programs and supports for caregivers. There will also be more investment in specialized nursing teams within emergency departments. This isn't new, but we'll see more of it to identify at-risk individuals earlier and connect them with community supports. And they've announced more investments in programs such as Hospital at Home that will provide patients with additional transitional services and specialized things like beds and lifts and other equipment that will help them safely leave the hospital. The third pillar on reducing surgical wait lists, I'll try to make this brief because I could go on forever, but we're really in the midst of a sea change in how we approach this. The surgical backlog is really not what it is believed to be. The problem is that of those waiting, we have a higher proportion of people who have been waiting too long. So they've exceeded the maximum recommended wait time. And so a lot of the funding realignment is really based on finding those patients who have been waiting too long, rather than focusing on just volumes for volume's sake. We all know that this kind of allocation drives activity, but we really need to drive the right kind of activity. So regardless of what kind of a surgery or procedure you're waiting for, you should be done in a reasonable amount of time. Currently, the number of people being off-listed from surgical wait lists approximately equals the number of people being on-listed. So the surgical wait list in total is not growing, but we really need to focus on getting those long waiters down. There's also additional funding for more operating hours for MRI and CT. The MRI and CT volumes actually are up to pre-pandemic levels and above, but the waits, as you all know and I know, are still too long. So there will be more operating hours for those diagnostic imaging services. More funding for additional training for surgical staff to improve management of wait lists. There's going to be an acceleration on central waitlist management to get that up and rolling. And they did mention, as you all know, options for further increasing surgical capacity by leveraging non-public hospital assets. This is another one of those devil in the details things, I think, where we have to be very certain that when we talk about IHFs, we want that I to stand for integrated, not independent, functionally. And so they have to be fully part of the system to make sure that we don't get unintended consequences like HHR diversion and building capacity in the kinds of things that we don't need to build capacity in. So this will be very important work going forward to make sure that it's done right. Fourth pillar is easing pressure on emergency departments, and I'll abbreviate my remarks just in the interest of time. But the most important thing, I think, is the peer-to-peer support program, which the Emerge Docs have been calling for a long time. So this will be run through Ontario Health, And there will be an emerge doc that is not working, who is available to provide with video technology and other kind of real-time support, the ability to sort of walk through a case for, say, the new grad who's working in a northern emergency department. We really think, based on success of a similar program in BC, that this will really help recruitment and retention for some of the emergency departments that have been chronically plagued with staffing problems. The ministry also is working with the College of Physicians and Surgeons and the Nurses College on expediting the registration of docs and nurses who may be internationally trained or are otherwise just short of what is needed for registration to get those folks into the field. Increased access to the family health organization model of primary care. This will be in part for net new doctors, also for existing doctors to improve access to primary care, including the important after hours provisions in some of these contracts to help reduce the demand on emergency department care.
Chris, sorry to interrupt you. I know you have one more point left, but I'm just going to do another time check, and there's lots of great comments to you in the chat that I wanted to also get to. So.
All right, I'll wrap up in 30 seconds. The last one is the wicked issue of our time, HHR, further expanding Ontario's health workforce. So I mentioned the internationally educated workers, long-term care recruitment and retention. There's going to be an increase in the number of nurse practitioners working in long-term care homes. And lots of work on increasing the numbers of personal support workers. But I'm not going to sit here and pretend that one's easy, or any of these are easy. The HHR problem is not going to be fixed overnight, but hopefully some of these immediate steps, combined with the fact that we're coming off wave 7 and people who are off sick are coming back to work, will give us a little bit of a reprieve. But this is going to be heavy lifting. So I'm sorry, this topic really doesn't lend itself to a 5 to 7 minute talk, Tara, but I'll stop there.
Thanks, Chris. Yeah, no, it's hard to summarize that 5-point plan and also acknowledge, I think, the important work we're doing and where we are in the system. And I just wanted to summarize a few of the comments that are in the chat. And I actually hope that maybe you'll have time to just go into the chat and read them and maybe even respond. I think we're hearing over, people were very appreciative of the acknowledgement of the hard work that we're doing, Chris. At the same time, people were expressing their strong disappointment that family doctors weren't valued or mentioned in the plan. And people said very disappointed they weren't valued, and others said not mentioned. I think people drawing the connection between strong family medicine and the emerge department. And I'll just read this from Kim. Kim McIntosh, thanks for the kudos, Chris. Now let's make that the solution. ALC and ER pressures are only corrected if family doctors and primary care teams are supported and distributed throughout the province and funded and prioritized. Must be the next focus and articulated that way. So I think that sums up a lot of the comments. I will also say there are a lot of colleagues on the chat who talking about their own burnout and difficulty and interest in, even potentially contemplating retirement, something they never did before, but feeling all of the ways in the system is collapsing back on them, and not being able to hire help. So, having something really tangible that people are asking for actually is a locum program or support to get locums so that they can take a vacation. Kim, I think, mentioned how she paid $7,000 for a 2-week coverage just to rest, and then came, and she was just feeling grateful that she was able to do that and actually find someone. Lots of comments in here, lots of comments about the home care situation, long-term care, et cetera. So I'll let you read them, Chris. I hope that's okay. I want you, if you wanted to, just react to some of that right now, that's you're welcome to. And then I think we'll close out with a couple of COVID things.
Sure. Well, I appreciate all the comments, and I think that a lot of the what's been missing, I think, from some of the public discussion is just a simple expression of solidarity with the people who are doing the hard work. And I know everybody wants solutions, and we need to develop solutions. And in fairness, I think the government response is a reasonable first shot across the bow to try to get some tangible successes. But I think it's really important for leaders, and that includes, all of you on the call, to to be kind to each other, to acknowledge, what this has meant to all of us who are working. And I think when problems are minimized, or we use language that is, sort of dismisses some of these concerns, it just serves to invalidate, what everybody is feeling. And so we just simply have to acknowledge this ain't a fun time, and we need to support each other. And I think, OH and the ministry needs to support as well. So a big part of this is just going to be telling the truth, acknowledging the hard realities that are out there, and holding ourselves accountable to, turning this into an opportunity. And I hate to sort of, suggest that we all need to suddenly become optimists, but this really is our one in a generation chance to do some of the things that we all know need to be done to create a real system of care. And so by supporting each other, and by being honest with each other, telling the truth, I think we can get through it together. So I'm committed, and I know I don't want to speak for Liz, but I have a lot of admiration for Liz and the things she said in the past, and her vision. And we really, really want to work with the primary care community to make this better. So hopefully we're at a trough, and we'll start to see some positive things happening.
Thanks, Chris. So maybe I'll turn it to Liz to just maybe provide some remarks as well, but I'm going to just call it a couple of things. One is we did hear the suggestion in the chat actually about us having a session that was more focused on this. So we'll take that back and think about how we can support that, because there's clearly a lot of interest in dialogue here. I will also ask our team to print out the chat so that Chris has it, so that all those comments are not lost, because I think those are terrific. And then I did wanted to point out that many of you may not know that Liz is transitioning to a new role at Ontario Health in September. And I know, Liz, I wonder if you wanted to speak to that, but also to just comment on what we've been hearing in the chat and what Chris said.
Yeah, thanks, Tara. And thank you, Chris, for being here and for making time. We know, you're on your own holiday here, and it was important for you to speak to primary care and family doctors, and so grateful for that. And I think I posted the message that the OCFP released, which really summarizes everything you've put in the chat, right? I mean, I think what we know is on the one hand, acknowledging the hard work and the level of burnout, fatigue, distress, moral injury, and also just the point that we can't solve the system if we don't include all parts of the system. And clearly the pressures in hospitals and emergency departments are directly related to do we or don't we have a strong foundational primary care system. And we know the lack of investment in our sector goes back decades, So I agree with you. This is an opportunity. I think I am transitioning from my work at the OCFP, where I feel like we've really stepped up to recognize, advocate, speak to what we're hearing from family docs across the provinces. So across the province. So I want to continue to just ask you to let us, reach out to us, let us know what you're hearing. Know that we are actively working on things like recovery plans and very specific actions that we're going to bring forward to government on, that fit in some of those 5 areas and that really focus on family doctors. I will be moving into, it's a new role at Ontario Health. So I think that's a good sign that Ontario Health is saying, we're going to increase the work that's being done in primary care. And so I'll be helping to lead that. So I hope that starts in September. So I will, continue my work to do the work that we know we need to do to build up primary care as a sector and to support our profession. So my nose is to the grindstone. My heart is with my colleagues. I am optimistic as well. I do feel there is an opportunity, and I think we need to continue to support each other and press the solutions that we know are going to make a difference. So yeah, maybe I'll end there, and I think happy to hand it back to you, Tara, and just if people want to go back into COVID. And I mentioned in the chat, Tara, and I will take that back, about doing a session specifically on this. We've talked about doing that before, like on this in terms of the health system, and maybe bringing some partners together to speak to family docs about, recovery and hear what you have to say and talk about, concrete actions. So that's definitely something we'll take back. Thanks.
Thanks, Liz. I do know we're at time, so I apologize that we won't be able to get to other COVID questions. I know there's some outstanding ones related to the nitrous oxide nasal spray, for example, but I think that'll need to wait, or we can try and put some information in our FAQ about those things. There were also a number of questions about boosters and timing that we didn't get to, but I did want to just highlight that we do have an updated resource at confusedaboutcovid.ca, very specifically about boosters, and it's been continued to be updated by Andrea Chittle and our team. And I think these tables are very user-friendly, and lots of information in addition to those tables and that booster dose document that's helpful for patients, but also actually for clinicians. So check that out. Next slide. We are going to reconvene again in September 16th. We're going to actually do a focus session on long COVID at that time. And we have a great panel lined up for you, including Dr. Angela Chung, who is the researcher leading many of the COVID studies across Canada. I wanted to really thank all of you for your engagement today at the session. And I wanted to thank our panelists for making the time. You're busy in your work life, and a lot of you are busy, personally as well. I know 2 of you joined us today on your vacations, and pretty grateful for you to be able to do that, so that we can have the information we need to do our work, and for us to have your support and have that articulated means a lot. So thank you to Upton, Alan, to Amanda Adams, to Dan Warshevsky, and to Chris Simpson for making the time to be here today. Thank you to all of the OCFP team and DFCN team behind the scenes, including Olivia O'Neill, who controls all of the IT in the background. And we'll be posting the video usually by the end of today, as well as the slides, so you can take a look at that as a reference, and we'll be sending out the Q&A and posting that shortly as well. So thanks to all of you for everything you're doing. We'll see you again in mid-September. I hope you enjoy the last couple of weeks of summer before the school year starts. Take care. Bye-bye.